Improving productivity is probably the single greatest challenge that the NHS faces over the next few years, and mental health services are going to have to play an important part of that. That's why the King's Fund and the Centre for Mental Health decided to work together on this report. Mental health is important because, firstly, it's a very significant proportion of NHS spending, and also secondly, it's an area that could possibly come under particular financial pressure over the next few years. The good news is that there are opportunities to improve value for money in mental health. There's examples from different parts of the country of innovative things that people are trying.
Out-of-area treatments are where individuals need a placement, either residential care, nursing care, or even possibly secure care, and we don't have the provision locally within the borough to be able to provide for that, and we need to purchase individual placements out of the borough. In Islington, we decided that we needed to do some work around our out-of-area placements in about 2004, and we funded a post, an out-of-area reviewing post that was also a research nurse post. At the time, our budgets were overspending, and we knew that that wasn't sustainable, that we had to do something differently, and that we couldn't keep just placing people out of the borough.
My role is to carry out comprehensive reviews of service users who are placed in out-of-area treatments, to look at their level of function and look at their suitability for relocation, look at whether the service they're receiving matches their needs. And it all stemmed from previous research that was done over the last few years, which identified some concerns. Service users were found to be over-supported in out-of-area placements. Also, some service users were found to be socially dislocated because those placements were often far away from their home.
24 people have moved back into the borough over the course of the project, and 11 of those people are now living independently. They're living in their own tenancies. So they've moved from being in residential care, and often very institutional residential care, to living now independently in the community in their own flats.
And to me, this is a fantastic outcome in terms of offering people choices, allowing them the ability to make their own decisions, to choose what they want to eat each day, living in their own accommodations.
Assessment processes in mental health are an area that the evidence base is really clear that if we could just improve that, we could make a huge difference to patients and to productivity. If we take, for example, the IAPT, Increasing Access to Psychological Therapy project, that's allowed GP referrers to know exactly what information routinely the specialist mental health trust needs when it's assessing patient. And if we then look at what happens when somebody comes into a mental health team in secondary care, again, across the world, in some of the best, most efficient healthcare systems, a lot of emphasis is put on training every single frontline member of staff who's going to assess a patient in really expert assessment. Sometimes that's done by tele-assessment, which a lot of patients, particularly people who are working, can often prefer. So the benefits in terms of quality are more targeted information, less trauma for the patient and having to tell the story over and over again, better communication between clinicians, faster access to the service that people really need. Patient satisfaction is significantly increased, referrer satisfaction's increased, and interestingly, what the evidence seems to be routinely showing is that often as many as 40 to 50% of people who are assessed in this expert tele-assessment way don't actually need to come for a face-to-face appointment.
Supported employment for people with severe and enduring mental health problems is quite different from the supported employment that exists more generally. It works on the same principles around supporting people effectively into jobs, but I suppose the kind of key differences are that it's a very individualised approach, very, very personalised, very much led on the person's wishes and wants. It's also totally integrated with clinical treatment. I think the key key part of the service user journey is right at the start of their kind of contact or working alongside mental health services, really establishing what is it that the person wants to do as a kind of life beyond having an illness. And for a lot of people, as part of their recovery, people talk about having a motivation to return back to work. From our own kind of evaluation processes, we've seen that 39% of the people who we help are able to go back and maintain jobs, which is incredibly positive in relation to kind of other figures that exist from other services. The figure's even greater for young people who often experience a first episode of psychosis, where up to 69% are returning back, not only to employment, but also finishing off their education and making the transition then into their first job.
Service providers and commissioners are going to have to work really closely with the people that use their services and also with the clinical teams that provide them if they're going to achieve some of the opportunities that we talk about in our report. They'll also need support from national government and from other organisations at the national level. They'll need support, for example, in using pooled funding mechanisms that will make it more financially viable for them to invest in new forms of service delivery. And we also need to continue investing in research, particularly around prevention of mental health problems that could deliver cost savings in the future.